So I'm here on behalf of our group in Sapienza. First I will talk about No-Reflow phenomenon. Then in the second presentation, which was planned to be held by my colleague, our radiologist, Dr. Angeloni, I will talk about our experience, our real-life experience with CERCare. So let's talk about No-Reflow phenomenon first. I do not have any disclosure. So, first issue, futile recanalization. What is this? These are cases in which after LVO, after large vessel occlusion and successful recanalization, so a perfect mechanical thrombectomy, the patient doesn't reach the functional independence. So for us, functional independence is always defined with the 90-day modified Rankine scale. So the patient do not reach a modified Rankine scale of 0-2. Futile recanalization is not negligible. You see that in clinical trials, so in a perfect settings, it's about 30 to 60% within 6 hours and 30% within 6 to 24 hours. In real life study, it's nearly half of patients who do not reach functional independence at 3 months. Another way of measuring it is failure of early neurological improvement. So the absence of improvement at the NIHSS, normally at 24 hours and at 7 days. So definitely, recanalization is necessary for our patient, but is not sufficient. We need reperfusion, which is a different concept. So one possible explanation for futile recanalization is the No-Reflow phenomenon. This is not a new concept. This dates back in the 60s. It was first studies in animal models, and it was observed like absence of perfusion in parenchymal microvasculature after ischemic injury, even after restoration of patency in the main artery, in the big artery. Then, as always, cardiologists were better and faster than us, so it was defined in myocardial infarction patients as angiographic coronary flow reduction after recanalization of coronary arteries. Let me make a practical example. This is Rome. You see there's a big highway all around the city. Let's say you restore the traffic flow in the big highway. So yeah, problem solved. No, in the little street inside Rome, this is the situation. So the problem is not solved. So where does this No-Reflow phenomenon comes from? Actually, it has a quite complex pathogenesis. So we can divide it in 3 big groups. First, problems in the vascular wall structure. So edema of endothelial cells, vasoconstriction, and pericyte contraction. Then endovascular factors, so aggregation between neutrophils and platelets, or RBC and white blood cell stacked in capillaries, but also microthrombi and fibrin deposition, and then also some extravascular factor in ischemic stroke after the hyperacute phase. We have vasogenic edema and blood-brain barrier disruption. These may compress the capillaries. So you can understand that it is really complex pathogenesis. And do we know how to identify this No-Reflow phenomenon in our patient? No, to date we don't have a reliable method to detect No-Reflow phenomenon in acute ischemic stroke patients. So some groups tried to define it in different ways. This is a study from an Australian group trying to detect No-Reflow phenomenon in patients with successful recanalization, trying to define the pulsatility and the resistance index in this patient after recanalization. they compared this pulsatility and resistance index intersite, so in the affected MCA and contralateral MCA. Then they compared this patient with controls, and they compared this data of resistance with the MCA of the controls. So first we can see that all the patients with the affected MCA had higher resistance index at the transcranial Doppler as compared to controls. But what is interesting is that there was a relation between increased pulsatility index and reduced chances of excellent outcome at 3 months. And they saw also that this patient with increased pulsatility index had less chances of hemorrhagic transformation. But still, transcranial Doppler is really dependent on the operator, so needs for high expertise. We don't always have a good temporal bone window, and maybe it is not so reliable in large infarct and in case of ICH because of increase of intracranial pressure. Then maybe perfusion imaging could help us in detecting No-Reflow phenomenon. The first study is a French study which tried to identify No-Reflow phenomenon with arterial spin labeling. So for them, the definition of No-Reflow phenomenon was more than 40% reduction in cerebral blood flow in 24-hour MRI arterial spin labeling maps. Actually, with this definition, they found this No-Reflow phenomenon just in 1 patient out of 33. So at first, they conclude maybe the No-Reflow phenomenon is not so common as we think in our patient. But actually, when trying to push the threshold, so trying to define it with a mild hypoperfusion, 1/3 of patients had this mild hypoperfusion at 24 hours. Another study on perfusion was the study, this is always a study from Australian group, which defined No-Reflow phenomenon as a difference more than 15% intersite asymmetry of relative cerebral blood volume and flow within the infarct lesion as compared to the contralateral one. They found that the No-Reflow phenomenon defined with this definition was present in 25% of patients, which is quite the described percentage of in vivo models. And they find also that this definition, No-Reflow phenomenon, predicted clinical outcome, both 90-day modified Rankin scale and NHSS at 24 hours. Moreover, patients with No-Reflow phenomenon had higher chances of hemorrhagic transformation. But first, there was a visual assessment. Then there may be an issue of spatial resolution with this hemodynamic data of perfusion. As we know from animal models, No-Reflow phenomenon should be mottled. So maybe No-Reflow phenomenon is something less than 1 millimeter, but mottled within the infarct. And then the perfusion imaging may be influenced by carotid artery stenosis, high burden lesion, ejection fraction, and so on. Then another really interesting study is the CHOICE trial. This was a trial of the Barcelona group enrolling patients with successful recanalization. So you see a ETC score among there to be 50. And they randomized patients to intraarterial alteplase versus placebo. The results were tremendous. I mean, patient with intraarterial alteplase, as you can see from Grota bars, had definitely better outcome than placebo. But what interests us now is that they did also a post-hoc analysis of about 40 patients who had follow-up perfusional imaging to see if there was no reflow phenomenon in these patients. No reflow phenomenon was defined by this group as any hypoperfusion at CBF within the infarct core. And actually, what they found was that a patient with intraarterial alteplase did not have had less percentage of no reflow phenomenon defined in this perfusional way. Finally, DSA could be another way to define no reflow phenomenon. DSA, as compared to the other possible definition, is a more dynamic evaluation. We have different phases. We have an arterial phases, capillary phases, venous phase, and a contrast mediostasis could be a sign of microcirculatory thrombosis. So in our study we did in our center, we tried to identify no reflow phenomenon in post-interventional DSA, so just after recanalization, and see if it correlated with futile recanalization and failure of early neurological improvement. It was a retrospective study, just anterior circulation occlusion and patient with successful recanalization. So basically this was our definition. We divided the MCA territory in 3 segments. For each segment in the capillary phase, we gave a score from 0 to 2. 0 if the capillary blush was absent, 2 if normal, 1 in delay. In the first image you can see a patient who had delayed capillary blush in all segments. In the other one, the capillary blush is perfect. So the first one should be a patient with a no reflow phenomenon according to our definition. So we also looked at a threshold to define no reflow phenomenon, which was defined as a score of 3 at our modified capillary index score. And we tested it for failure of early neurological improvement. And our definition seemed to predict both failure of early neurological improvement at 24 hours and at 7 days, as well as hemorrhagic transformation. So now let's go to the future. So Professor Ostergaard described well capillary transit time, what it is. So this is just a summary. It determines the time available for blood tissue diffusion exchange before the blood leaves. So in the capillary transit time is not homogeneous in tissues, but there is an heterogeneity which should be considered in our flow models. The erythrocyte flow varies a lot during rest, but also in pathological conditions. So from a mathematical point of view, CTH corresponds to a sort of standard deviation of blood transit time. So this is, I think, the most important article on the argument in ischemic stroke. So in this study, they looked at a patient from the preconditioning Horus study. In a part of the study, through a computational model, they created a model of different perfusional parameters in different stages of acute ischemic stroke. So let's focus on CTH and RTH. Professor Ostergaard already explained what we are talking about. What they saw was that in a first phase, in which perfusion pressure declines, we have increase of both CTH and RTH. Then there is a second phase in which still increases both CTH and RTH, and this phase should be the capillary constriction one. Then the first phase, we have a decline of both CTH and RTH, and this should be what the authors call the capillary constriction or no flow. What they saw also is that low levels of RTH in not recognized patient predicted the infarct at 24 hours. So starting from this, I will present you some really preliminary data of a study we are doing in Sapienza. In our center, we have a protocol of perfusion imaging for all our stroke patients, even in the normal time window, before the thrombectomy, but also in the 24-hour control. We always do a 24-hour MRI with perfusion imaging. So we wanted to explore if there was some association between the CTH in particular, so the capillary heterogeneity, and 90-day functional outcome. Always a retrospective population, always anterior circulation occlusion, always patient with successful recognition, so a modified TDC score to C3. So, thanks to Circle Group, to Mikkel in particular, we could have a definition, an output of these parameters, of these different parameters within the infarct lesion defined with the DVY and with the ADC. So we had both this parameter within the infarct lesion, within the core lesion, and a mirroring lesion. So we could also have calculate a relative parameter, relative CTH, relative TTD, and so on. So this is just the descriptive analysis. Just to say, these are just 37 patients. I told you it's really preliminary data. But we observed that patients with a poor functional outcome, so with a modified Rankin scale 3-6, had higher ipsilateral CTH as compared to a patient with a good functional outcome. This is the graphical presentation of what I'm saying. So then we thought to make a first multivariate model. Of course, we're talking about 40 patients, so we just corrected this data for age, sex, and severity of strokes for baseline and IHSS. As you can see, there was an inverse association between ipsilateral CTH and good 90-day functional outcome. But for the relative CTH, so for the ratio between ipsilateral CTH and contralateral CTH, this was a direct correlation. This was confirmed also, when considering MTT, because what I did not told you about the Jespersen study was that actually they observed that there was a dependence between a correlation between CTH and MTT. That's why they used the RTH. But actually we did not find in this first 40 patients, and even if when correcting the data for MTT, the association between CTH and modifying Rankin scale was maintained. This was not true when considering infarct volume, but we need to enlarge our population. Also for MRS01, we found some trends of this association, so for excellent 90-day functional outcome. So these are just some examples. So of what I'm talking about. This is a patient with successful recognition of M1 occlusion, which at 90 days had a poor outcome, so modifying Rankin scales 3-6. You can see he had also a hemorrhagic infarction, and the CTH is increased all around this hemorrhagic infarction. This is another patient with a lesion, 24-hour lesion, in which CTH is normal or reduced at 24 hours and yet a good functional outcome. And this is another patient also successfully recanalized. I want to look at this little lesion, this little DY lesion. You see that there the CTH is increased. I don't know, I don't have the answer. What is this? Is this No-Reflow? Is this something other? I don't know, and we need to enlarge our population and follow with our study to know what we are looking at. Another patient, quite big lesion, but still, CTH was normal or was reduced, and MRS 0.2. So, what we found in this really preliminary data was that higher CTA was more frequent in a patient with a poor outcome at 90 days. Is this No-Reflow phenomenon? We don't know, maybe it could be. This seemed to be in contrast with previous data from Hagendal. Just to remember the three phases they described. But we are talking about different populations. They created a model on acute MRI, so pre-recanalization. Our cohort is made of a recanalized patient evaluated on post-treatment MRI within 24 hours. We found also a trend for lower relative CTH in patients with worse outcome. Maybe this depends on the contralateral CTH. We should consider also leukoariosis and chronic microvascular damage. We need to confirm this result, of course. In this case, if we confirm this increased CTH in patients with worse outcome, what are we looking at? Maybe we're looking at the phase 2, so capillary constriction. I hope it is so, because this means maybe there is a reversibility. Of course, preliminary study, preliminary result, no strong conclusion. We need to enlarge sample size, evaluate also the effect of the other hemodynamic and metabolic parameters, adjust data for chronic disease. And also in a prospective study, we plan to compare all the methods we have today to detect No-Reflow phenomenon. And just to remember, it's a complex disease, it's a complex phenomenon. So also when we will think about treatment, we will have to think where we want to act, in which of these three groups. So recanalization is necessary but not sufficient. Imaging marker of No-Reflow phenomenon is lacking today. Perfusion imaging might be a valid method. Also DSA might be a valid method. And as well as CTH, which allows us to see the capillary obstruction, but also constriction. Future treatment should consider how complex is this No-Reflow phenomenon. Thank you.
Thank you very much for this exciting talk. It was really interesting to see, especially in the Ingedal paper. We focused a lot on permanent occlusion because we wanted to see the fate of the tissue. And I think this is the first we really get to see of what happens with recanalization, where you know where it actually happened. And I found that extremely fascinating. Thank you so much. I shouldn't talk all the time, so questions from the audience? Otherwise, I would actually like to say that what you did with the contralateral CTH and CTH within, that was really, really interesting, because what we should remember is that when a stroke patient comes to you, they've been exposed to risk factors throughout their life. So it means that they come there with a microcirculation that we actually don't know how that works. You know, have they had hypertension for a long time, or what have they? So I'm trying to figure out whether the data you show are actually can be used to say something about how that microcirculation in that individual patient is affected by the stroke.
Yeah, from what we know from futile recanalization, let's say cognitive impairment is a strong predictor of futile recanalization. So maybe a patient with this elevated relative CTH just had a high burden, microvascular burden from a chronic point of view. But still, we should adjust also for Fazekas. In the prospective study, we will consider all these data, of course. Of course, chronic disease should be considered.
Super interesting talk. Look, and you scan them at 24 hours in these preliminary results. Have you tried to look at the data from the B-tube at the DSA post-thrombectomy and correlate that with the 24-hour MRI perfusion?
So the data from the B-tube, but this was our first analysis, so we didn't look at that right now, but we should definitely.
Yeah, you probably should. We have actually scanned a few patients now, and we're starting to systematically scan them directly after thrombectomy, going directly into the MRI scanner, and there's a lot of stuff happening in the first 24 hours as well. And we see very few patients now, but we're going to start more systematically doing it. But I think that the DSA images can be used to estimate some of these things. If you're not able to do direct MRI after thrombectomy.
Direct MRI would be like the perfect thing. Our MRIs are always within 24 hours, but if we have to think about animal models, we know that there's no reflow phenomenon until 6 hours, then we don't know what happens. So all this data on 24 hours, we don't know what happened in these 24 hours. It's a lot, 24 hours. So we should consider, as you said, if we can direct MRI, but this is really practically difficult. Or DSA. We have we tested DSA because DSA had this thing of testing just after, you know. So this is a totally we should correlate with after.
The results are super interesting, and it would be really interesting to see the DSA as well for these patients, probably.
Yeah, and then, you know, we should record also timing of our MRIs to see if there is a difference even hour after hours.
I guess you didn't, at your place, you decide who gets an MRI right after the thrombectomy.
I am a neurologist, I go there.
They stand outside the door. Thank you so much for that wonderful talk and for the questions.